My presentation would focus on the administration of the injection itself once we've decided that TPA is to be given. So the preparation part, so Actelize brand name out here comes with a 50 milligrams preparation. In the West, they have 100 milligrams preparation. So I'm going to tell you how to prepare the injection of 50 milligrams. So here it is, one vial for the injection, the other vial which would contain sterile water. It should always contain water. There's no point having normal saline here. We put this plunger in the vial containing water, and you put this plunger inside the vial containing the powder. So like this. So care is to be taken to make sure the plunger goes right through the center. So once there's a fit, turn the bottles upside down, wait for the water to drain down completely into the bottle containing the water, the injection. So once all of the water is transferred, you may take it out, very gently shake it once and put it down. So now would come the administration part, this infusion pump. There was a time use burettes or microburettes for the same purpose, or even the injection itself. Once constituted, we could hang it and set the drops according to the required dose. But now infusion pumps which are modern and out there in the West, which are actually formulated for TPA itself. What you have to do is you just enter the weight, and then it would run on its own as per, this is how the injection looks. So there that I've already demonstrated. Infusion would then run in a burette like this, attached to this, and this out here, now you can enter the weight, and it's designed to complete in 1 hour, the infusion. So things to monitor while the infusion is going on. Obviously, the vitals need to be checked as per the protocol on a separate observation sheet. As a rule, the blood pressure needs to be monitored every 15 minutes for the first 1 hour, and then every half an hour for the next 2 hours, and then at least 1 hourly for the next 24 hours. This is what we are doing here in practice. Blood sugars should remain in the target range, which is usually 140 to 180 milligrams per deciliter at all times during the administration. In case the blood pressure goes beyond the target range, which is 180 by 100 to 185 by 110, we may switch to agents like labetalol, which is very effective, 10 milligrams bolus IV over 1 to 2 minutes, and we may repeat the dose if required every 10 minutes. Things to avoid are isokit. We find that isokit in lowering down blood pressure is not very useful. Avoid all kinds of tubings like an NG tube or a Foley's. Things to look for: anaphylaxis and angioedema. Obviously, alteplase is something which could cause anaphylaxis and angioedema. In that case, the infusion needs to be stopped. It should be figured out if the patient is on ACE inhibitors, because for people who are on ACE inhibitors would have certain levels of bradykinin already in blood, so that has to be considered. And chlorpheniramine, ibisolocortef, all of these things can be given. And then if the anaphylaxis is settled, one can start again. So the red flags, which should make us stop the administration of TPA immediately: a new onset seizure, acute hypertension beyond 190 systolic, nausea, vomiting, or any hard, concrete neurology, new onset. So that is one indication that the administration of the alteplase should stop immediately. So I would touch briefly on the topic when to consider mechanical thrombectomy. Obviously, it would be discussed in detail by worthy guests. So, large vessel occlusion criteria. This is especially for our residents. When do you suspect large vessel occlusion? This one should know. What are large vessels? Large vessels of the brain. the internal carotid, MCA, M1, M2, the vertebral, the basilar arteries. So there are lots of criteria which are used in stroke assessment to assess large vessel occlusion. Unfortunately, there is not consensus on all of them, but here I have a race criteria, rapid arterial occlusion criteria. It has these 6 items to look on, starting with facial weakness, arm motor function, leg motor function, and you can grade those items according to the deficit found. For example, in facial weakness, if there is no deficit, the score is 0. If there is a mild deficit, the score is 1. And if there is a moderate to severe deficit, the score is 2. Total score is 11, 0 to 9 out of 11. If the score is more than 5, that would largely mean a large vessel occlusion. General eligibility criteria for mechanical thrombectomy. CT should obviously exclude hemorrhage, NIHSS more than 6, aspect more than 3. So these are the basic eligibility criteria. CT angio demonstrating large vessel occlusion in anterior circulation. So then subsequently thrombectomy can be started within 24 hours. So this was it from my side.
Thank you very much, Dr. Salman.